This patient has Tetralogy of Fallot requiring surgical repair. This video shows a surgical procedure. There will be cutting and sewing of live human tissues, and blood and other human bodily fluids may also be visible. Viewer discretion is advised. Off-screen, the cardiopulmonary bypass circuit has been run up to temperature and adequately deaired. The pump is stopped and the circuit is divided between two pairs of line clamps. The tubing on the side coming from the cardiopulmonary bypass machine is called the arterial limb of the circuit. An adapter for the aortic cannula is pressed into the end of the arterial limb. This is the other side of the loop, the venous limb of the circuit. The venous limb is partially drained and cut short off-screen with a Y adapter connected to its end. The drainage cannula for the superior vena cava is oriented correctly before being connected to the upper limb of the Y connector. The appropriate dose of heparin is administered. Heparin prevents blood clotting and allows us to take the patient safely onto cardiopulmonary bypass. Its activity is measured by a blood test, allowing us to determine when we can safely commence cardiopulmonary bypass. The ascending aorta is drawn downwards, and the cannulation site is incised with the number 11 surgical knife within the purse string. The tip of the cannula is inserted through the cannulation site, and the purse string is tightened. The cannula is then tied to the snugger, securing it. Finally, the cannula is deaired and connected to the arterial limb of the cardiopulmonary bypass circuit. The right atrium is drawn forwards and to the left to expose the inferior caval cannulation site. The site is incised with a knife and the cannula is passed through. It is positioned with its tip facing into the inferior vena cava with its tip facing downwards. The cannula is secured and connected to the lower limb of the venous Y connector. The clamps are released and the patient is taken onto cardiopulmonary bypass on partial flows. The right atrial appendage is once again drawn downwards to expose the superior caval cannulation site. The cannulation site is incised within the purse string. The tip of the cannula is inserted through the purse string and turned to face the correct direction, that is, headwards. The cannula is then secured and unclamped. The patient is now on cardiopulmonary bypass on full flows. A heavy silk tie is pulled around and behind the superior vena cava using the path that we developed earlier. Both ends of the tie are passed through an orange rubber snugger and the snare is tightened down, drawing the superior vena cava tight around the end of the superior vena cava cannula. Likewise, a heavy silk tie has been drawn around and behind the inferior vena cava, passed through an orange rubber snugger and the snare tightened down. From this point onwards, all the venous drainage from the body coming through the superior vena cava and the inferior vena cava will drain into the venous limb of the cardiopulmonary bypass circuit. The patient's heart, therefore, is seen to beat in a mostly unfilled state. A purse string for the Cardioplegia cannulation site is placed in the front of the ascending aorta, just far enough away from the return cannula that a cross clamp can be placed between them. The tip of the Cardioplegia cannula is introduced into the aorta through the purse string. The cannula is then secured, deaired, and connected to the Cardioplegia section of the cardiopulmonary bypass machine. A crossclamp is placed across the aorta between the return cannula and the Cardioplegia cannula. Then Cardioplegia perfusate is given, arresting the patient's heart.